Imagine this. A 3-year-old girl is pulled lifeless from an icy pond in the Austrian Alps. Her heart isn't beating. Her body temperature is just 66 degrees. For 2 hours, she has been clinically dead. And yet, a team of doctors and nurses brings her back to life. Not through magic, not through luck, but through mastering extreme complexity. Hundreds of steps, dozens of machines, a team moving with precision and discipline. And at the center of this miracle is a simple idea. When things become overwhelmingly complex, when the difference between life and death can hinge on just one missed detail, we need a tool to help us get things right. This is the story that Atul Gawande explores in the Checklist Manifesto. A story about how the humble checklist, a tool so ordinary that it feels almost embarrassing, can revolutionize medicine, business, aviation, construction, finance, and nearly every part of human achievement. A story about why, in a world overflowing with knowledge, expertise alone is not enough. Today, we're going to break down every chapter of this powerful book with clarity and precision. And by the end, you'll understand how something so simple can transform performance, save lives, prevent disaster, and help us get things right consistently. Let's begin. Chapter 1. The Problem of Extreme Complexity. In Chapter 1, Atul Gawande exposes a central paradox of the modern world. Humanity now possesses more knowledge and technological power than at any other time in history, and yet we continue to fail at tasks we should be fully capable of performing. These failures rarely arise from ignorance. Rather, they arise from an overwhelming level of complexity. Gawande illustrates this shift through dramatic real-world medical cases. He describes a surgeon treating a seemingly stable patient with an abdominal stab wound, an injury that initially appears manageable. The medical team performs every expected step with precision. They examine him thoroughly, monitor his vitals, provide fluids, and prepare for surgery. Nothing appears unusual until the patient suddenly crashes, losing consciousness and nearly dying within minutes. Only later is the shocking cause discovered. The wound had been inflicted by a bayonet. No one on the team had thought to ask about the weapon because such a possibility felt absurd in their setting. One missing question almost cost a life. In a second example, a middle-aged patient undergoing stomach cancer surgery suddenly flatlines. The surgical team cycles rapidly through every likely cause: blood loss, oxygen failure, collapsed lung, cardiac event. But nothing explains the cardiac arrest. The situation seems hopeless until a senior anesthesiologist identifies the real culprit: an accidental overdose of potassium caused by a minor concentration error. The team eventually revives the patient, but only after nearly losing him. These stories highlight the uncomfortable truth. Even highly trained experts, working with focus and urgency, can overlook critical details. Not because they are careless or unintelligent, but because modern environments demand flawless execution of hundreds of interconnected steps. The challenge is no longer the lack of medical knowledge. It is applying vast amounts of knowledge correctly, rapidly, and reliably. Historically, human errors were largely the result of what philosophers Gorovitz and McIntyre termed necessary fallibility, meaning the limits of what humanity could understand or control. Today, however, the primary cause of failure is what they call ineptitude, failure to apply known information correctly. Medicine, aviation, engineering, finance, and law now operate at scales of complexity that exceed the capacity of any individual's memory, attention, or judgment. Gawande demonstrates this shift statistically. For common medical conditions such as stroke, pneumonia, or asthma, studies show that 30 to 60% of patients do not receive appropriate recommended care, not because doctors do not know what to do, but because real-time execution breaks down. The more knowledge society acquires, the harder it becomes to manage. Chapter 2. The Checklist. In Chapter 2, Gawande turns to aviation to reveal a powerful solution. He recounts the 1935 U.S. Army Air Corps competition to select a next-generation bomber. Boeing's Model 299 was the clear favorite: larger, faster, and more advanced than any aircraft before it. Yet during its test flight, it crashed shortly after takeoff, killing 2 crew members. The investigation revealed no mechanical malfunction. Instead, the pilot had forgotten a seemingly simple step: disengaging a locking mechanism on the elevator controls. The conclusion stunned military officials. The plane was considered too much airplane for one man to fly. But instead of abandoning the design, a group of test pilots created something revolutionary for its time: a pilot's checklist. The checklist did not contain complex technical instructions. Instead, it covered the most basic essential steps: release locks, verify instruments, check fuel mixture, adjust flaps, secure doors. Details pilots already knew but could easily forget under pressure. The checklist transformed the operation of the aircraft. With it, pilots flew 1.8 million miles without a serious accident, and Boeing ultimately produced nearly 13,000 B-17 bombers, becoming a decisive factor in World War II. The lesson is profound. Even highly skilled professionals cannot rely on memory alone when managing complexity. Checklists protect against cognitive overload, distraction, and false assumptions. They do not replace expertise, they support it. Gawande also addresses the resistance many professionals feel towards something so simple. Doctors, engineers, and pilots often view checklists as beneath them. To admit needing one feels like admitting inferiority. Yet the data proves otherwise. Checklists do not reduce freedom or intelligence. They prevent avoidable catastrophe. Chapter 3: The End of the Master Builder. Chapter 3 explores how the traditional idea of the expert as master has become obsolete. For generations, society believed in the hero expert, the master architect, the genius surgeon, the Top Gun pilot, who possessed complete knowledge and complete control. But in modern environments, the complexity has surpassed the capacity of any single individual. Gawande uses the design and construction of skyscrapers to illustrate this transformation. Building a modern structure requires thousands of independent steps, dozens of specialties, and continuous coordination over years. A single failure, an overlooked measurement, a misinterpreted instruction, a missed safety test, can result in catastrophic collapse. Yet compared to medicine, construction failures are rare. Why? Not because construction workers are smarter or more talented. It is because the industry acknowledges complexity and designs systems that compensate for human limitations. These systems include coordination protocols, scheduled cross-checks, standardized communication, and checklists that ensure alignment. Instead of one master builder commanding every detail, success comes from distributed responsibility and predictable processes. Gawande contrasts this with medicine, where the culture still glorifies autonomy. Doctors frequently make decisions independently without structured coordination, resulting in unnecessary errors. In construction, the expectation is teamwork and verification. In medicine, it is independence and intuition. Chapter 4: The Idea. Chapter 4 introduces the early medical breakthrough that proves how transformative checklists can be within healthcare. Gawande presents the work of Dr. Peter Pronovost at Johns Hopkins Hospital, who set out to reduce central line infections in ICU patients, an issue that causes tens of thousands of deaths annually. Pronovost developed a simple 5-step checklist for inserting central lines. Wash hands thoroughly, clean the patient's skin with antiseptic, apply full-body sterile drapes, wear mask, cap, sterile gown, and gloves, and place a sterile dressing over the insertion site. These steps were standard knowledge, taught universally, and yet when nurses observed doctors, they found that at least one step was skipped in over a third of procedures. To enforce compliance, Pronovost empowered nurses to stop doctors from continuing if they ignored any step. This shift was revolutionary in a culture where nurses rarely challenge physicians. Over the first year after implementing the checklist, the ICU's line infection rate dropped from 11% to 0. In 15 months, the checklist prevented 43 infections and 8 deaths, while saving nearly $2 million. Pranavist then expanded the concept to checklists for ventilator care, pain monitoring, and post-operative protocols. Each resulted in remarkable reductions in complications and hospital stays. Yet despite overwhelming evidence, resistance persisted. Many physicians felt insulted by the implication that they needed a checklist. Others dismissed the idea as too simplistic for the complexity of medical care. But the results spoke louder than pride. Chapter 5. The First Try. In Chapter 5, Gawande explores what happened when Dr. Peter Pranavist attempted to broaden the use of checklists beyond a single process and apply them more widely throughout intensive care. The success of the central line checklist had been extraordinary, but it raised an important question. Could this same concept improve outcomes across other routine but complex ICU procedures? Pranavist and his team started by identifying areas in critical care where preventable complications were most frequent. One of the most serious problems they targeted was pneumonia associated with mechanical ventilators, a condition that affects thousands of ICU patients every year and is frequently fatal. They designed a checklist to ensure that key preventive measures were reliably followed, such as elevating the head of the bed to reduce aspiration, providing medication to prevent stomach ulcers, and administering anticoagulants to reduce blood clot risks. Despite the apparent simplicity, many clinicians had not been consistently applying these steps. The checklist changed that. Compliance soared, and hospital data revealed a dramatic decline in ventilator-associated pneumonia cases. This success encouraged Pranavist to implement additional checklists, including one ensuring that ICU patients received timely pain assessment and treatment. Before the checklist, more than 40% of ICU patients experienced prolonged periods of unmanaged pain. Afterward, the rate plunged to just 3%. The results were undeniable. Patient complications fell sharply, deaths decreased, and average ICU stays dropped by nearly half. But significant resistance remained. Many doctors felt that checklists reduced their autonomy or implied incompetence. Others simply struggled to accept that something so basic could produce such transformative improvements. Gawande emphasizes that humans are often drawn to complex solutions over simple ones, even when simplicity works better. Chapter 6. The Checklist Factory. Chapter 6 follows Gawande's journey to the source of some of the most refined checklist systems in the world: aviation. He travels to Boeing headquarters to study how the aviation industry designs and applies checklists with such precision and reliability. What he finds is that checklists are treated not as bureaucratic paperwork, but as critical life-saving tools. Boeing engineers explain that the key to creating an effective checklist is understanding that it must support human performance, not overload it. The goal is not to capture every possible instruction, but to identify the most essential steps, the ones most likely to be overlooked and most dangerous to forget. Through history, aviation learned these lessons the hard way. Early checklists were long and cumbersome. Pilots could not realistically use them during high-pressure situations like system failures. Trial and error led to the modern approach: concise, focused checklists designed for rapid use under stress. Boeing categorizes them into two types: REDO checklists, used when tasks must be done in sequential order, such as preparing an aircraft for takeoff; DO confirmed checklists, used after completing tasks from memory and verifying that nothing essential was missed. An effective checklist, he learns, contains neither too much detail nor too little. It must be practical, readable in harsh environments, and used collaboratively. In aviation, checklists function as communication tools, moments where the team stops, aligns, and confirms readiness. They create discipline, but also connection. Gawande also discovers an important insight. Checklists protect against two human weaknesses: memory failure and arrogance. Even the most experienced pilots rely on them. Expertise does not eliminate error. It must be supported by structure. The chapter ends with Gawande's realization that medicine needs checklists not as scripts, but as tools for coordination and clear thinking, just as aviation does. Chapter 7. The Test. Chapter 7 chronicles the defining moment when the surgical checklist was tested globally. After seeing striking evidence from individual hospitals, the World Health Organization partnered with Gawande to design and trial a universal surgical safety checklist. The goal was simple: reduce preventable errors in operating rooms around the world. They built an 18-step checklist covering 3 high-risk phases of surgery: before anesthesia, before incision, and before leaving the operating room. These included verifying the patient's identity and procedure, confirming equipment sterility, reviewing potential complications, checking medications, and ensuring that everyone on the surgical team knew one another's names and roles. 8 hospitals across diverse environments, ranging from modern facilities in Seattle and London to resource-limited settings in Tanzania, Jordan, and the Philippines, agreed to participate. The results were extraordinary. Rates of major surgical complications dropped by 36% across all sites. Death rates fell by nearly half, 47%. Infections and unexpected bleeding events fell dramatically as well. The most surprising finding was emotional rather than statistical. When surveyed afterward, 93% of surgeons said they would want the checklist used if they were the patient. Many admitted that although they resisted the checklist initially, they ultimately came to trust it and rely on it. The global test proved that the checklist was not just an administrative tool. It was a powerful method for improving patient safety across any environment, from state-of-the-art hospitals to developing nations with minimal resources. Chapter 8: The Hero in the Age of Checklists. Chapter 8 challenges the traditional perception of heroism. Society often celebrates dramatic acts of individual brilliance, the lone genius saving the day. But Gawande argues that in the real world of complexity, the new hero is the disciplined team player who prevents disaster before it happens. True heroism today requires humility, accepting that no individual can manage everything alone. It also requires a willingness to standardize and collaborate. By embracing the checklist, professionals acknowledge fallibility and create space for collective intelligence. One of the most profound impacts of the checklist is cultural. When team members review the plan together and speak up about concerns, hierarchy softens. Nurses and junior staff gain agency to challenge mistakes and ask critical questions. This change transforms outcomes, not by creating more experts, but by empowering more voices. The checklist turns individual excellence into group reliability. And in a world governed by high stakes and narrow margins, reliability saves more lives than brilliance. Chapter 9: The Save. In Chapter 9, Gawande closes by illustrating how the surgical checklist translated into real-world life-saving action. He recounts a case in which a young woman undergoing surgery began experiencing unexpected bleeding. As the team scrambled to respond, the checklist revealed a critical oversight. The patient had a known allergy to a blood product being prepared for transfusion. Without the checklist pause and review, the mistake likely would have been fatal. The reminder forced the team to stop, reassess, and choose an alternative approach. The patient survived. The power of this story is not in dramatic rescue, but in prevention. The checklist didn't give a team new knowledge. They already knew what to do. It simply ensured that nothing essential was forgotten. Gawande concludes that the checklist is not a miracle tool, but an equalizer. It cannot eliminate risk, but it can greatly reduce the likelihood of failure. It turns unpredictable outcomes into predictable ones and prevents moments where a single omission leads to catastrophe. In a world drowning in complexity, the checklist offers something priceless: a way to get things right consistently. Atul Gawande's message is clear. In a world of overwhelming complexity, we don't need more geniuses. We need better systems. The checklist is a tool that helps ordinary people achieve extraordinary reliability. Whether you're a student, a business leader, a doctor, an entrepreneur, or just someone trying to manage life, you face complexity every day. And the difference between success and failure may be as small as one forgotten step. A checklist won't make you smarter. It won't make your work easier, but it will make you more consistent, more confident, and more successful. The question is not whether checklists work. We know they do. The real question is, will you use them?